Okay, can everyone hear me now? I'm going to put up the slides in the meantime. Let's try screen, perhaps that's easier. Okay. Can everyone hear me? Lovely. Okay, perfect. Let's try this again. Can everyone see the slides as well? Just let me know if they're moving, so I know that everything is working fine. Oh, great. So the slides are not working. Let's try. Okay, great. Can you still see the slides and hear me? Lovely. Okay. Sorry, this was a double take, but now it looks like everything has been fixed. So my name is, let me see, why it's not changing the, oh, it's not letting me change. There you go. Oh, my screen is lagging. Apologies. Oh, my name is Roberta. I'm one of the, I'm a Neurology SFP FY1, and I'm one of the neuro co-leads for Mind the Bleep. I'm trying to understand why my slides are not switching. Okay, fine, there you go. So today's session is about central and peripheral nervous system lesions. We'll briefly go over the basics of our nervous system, moving on to common peripheral nervous system lesions that you encounter in your exams and potentially as an FY1 or FY2 working on the wards. We'll do some practice questions, moving on to central nervous system lesions. Again, most common ones that you'll see in your exams on the ward, and then finally a few more questions. So starting with the basics, this should not be new to you, but we can divide our nervous system into central and peripheral. Central being made up of the brain and the spinal cord, and its main function being input integration, higher level functions, processing, and generation of outputs. Now, those input and outputs travel through the peripheral nervous system, which is made up of nerves, and including nerve roots and ganglions, and that could be further divided into somatic and autonomic. The autonomic being further subdivided into parasympathetic and sympathetic nervous system. So, peripheral nervous system lesions. So two main things that you need to be able to identify and distinguish are neuropathies from radiculopathies. Neuropathies are commonly caused by conditions like metabolic derangement, such as in the case of diabetes, as well as vascular disease, so vasculopathies, vitamin deficiencies. I'm sure you know about the presentation of vitamin B1 and B12 deficiency, as well as infection. So commonly you would have heard of shingles and, well, Lyme disease. Whereas radiculopathies are more commonly seen with degenerative changes that affect the spinal cord. So we can get stenosis, we can also get trauma, tumors that invade the spinal cord, and also very commonly, especially in the younger population, slip disc. Yeah. So obviously, certain metabolic conditions can also affect radiculopathy, can also cause radiculopathies, but the mechanisms or the etiology that we see generally tends to be divided in this way. Now, they can both present as a polyneuropathy or polyradiculopathy, so multiple nerves or multiple nerve roots involved, as well as a mononeuropathy or monoradiculopathy, mono being only one. the way it presents will depend with the etiology, so the underlying cause. From a sensory point of view, they will both present with paresthesia, which is abnormal sensation, allodynia, which is a painful sensation result of non-painful stimulus, and potentially over time with sensory loss as well. The distribution of the sensory abnormality will be different, however. So in the case of neuropathy, they will follow the course of the peripheral nerve that's affected, or peripheral nerves if it's a polyneuropathy. In the case of certain conditions such as diabetes, we might have a very specific presentation. So you're probably all familiar with the gloves and stocking distribution in diabetic neuropathy. And in the case of radiculopathy, instead, it will follow what we call a dermatomal distribution. So you're probably familiar with the body's dermatomes. You must have seen a diagram 1,000 times. They can also present over time with motor dysfunction, so motor defects, so such as weakness. This will tend to present further down the line, so later on in the disease, depending on the type of the disease. And that is simply to do with the anatomical difference between the sensory fibers and the motor fibers. If it does present with some weakness or with some motor deficits, we tend to see, although this is not a fixed rule, that neuropathies tend to affect the distal muscles more and radiculopathies tend to affect the proximal muscles more. In terms of reflexes, goes without saying, we'll probably have diminished or even absent reflexes, again, depending on the extent of the disease. Another very common peripheral nervous system condition that we tend to see in hospital, especially in the acute setting, but also in your exams, is Guillain-Barré. So Guillain-Barré is a post-infectious, so after infection, immune-mediated, demyelinating polyneuropathy. And the myelin that's affected in this case is the myelin specific of the peripheral nervous system. It's post-infectious. We tend to see it a few weeks after, not immediately after, but a few weeks following an illness, commonly presenting with flu-like symptoms or a stomach bug initially, and then we tend to see the development of the symptoms of Guillain-Barré. One of the conditions that's most typically seen alongside this, one of the diseases that's most commonly linked to GBS is infection by Campylobacter, and that is due to molecular mimicry. So the proteins that are found in the outcoating of the bacteria stimulate our immune system to produce antibodies, and those antibodies, and because those proteins are quite similar to some of the structures present on the myelin of the peripheral nervous system neurons, are antibodies that mistakenly start to attack the myelin as well, which is why there's sort of a lag phase and then the symptom onset. And the symptoms typically present with asymmetrical, ascending, so bottom up, neuropathy, so paresthesia. So some of the symptoms that we discussed earlier, so abnormal sensation, weakness, we can get paralysis in sort of the slightly more advanced stages. The paralysis is typically flaccid because it affects the peripheral nerves. But in some cases, we get some special forms of GBS, which you may have heard of, such as Miller-Fisher syndrome, which can present with ataxia, areflexia, or hyperreflexia, and ophthalmoplegia. So you notice there's a dysfunction in the eye movements. It can also cause autonomic dysfunction, but we tend to see that further down the line. It's not one of the most immediate symptoms. How do we diagnose it? It's, I would say, largely clinical. A clinical diagnosis, the symptoms tend to be quite obvious, especially with the history that's given. But we can do CSF studies, and typically what this will show is a high protein level in the CSF, but normal white cell count. And that is because it's post-infectious. So there isn't an active infection that's causing it. It's just a sort of an inflammatory response, which is why the protein levels are high. We can also do neurophysiology studies or electrodiagnostics, and this will generally show a delay in the conduction, because you can imagine that if you're affecting the myelin, you're sort of prolonging the transmission time across that nerve fiber. How do we manage it? Typically, it's supportive management with painkillers, respiratory support if needed. In cases where the disease is more severe or patients present sort of with a worse worse symptoms, we can do IVIGs, plasma exchange. But the most important thing is that these patients will be spending a lot of time probably in bed, especially if they've developed paralysis as a consequence of the condition. It's very important that we give them appropriate DVT prophylaxis because they will be at risk of thromboembolisms. Another very common one, again, that you might see perhaps in the acute setting, more likely maybe in clinic, if you attend some neuro clinics, but definitely in the textbooks, is myasthenia gravis. This is a peripheral nervous system lesion that specifically affects the neuromuscular junction. And that is essentially the connection between our peripheral nervous system fibers and the motor fibers and the motor end plate, so of skeletal muscles. It is an immune disorder, which means that it's our own immune system that's attacking structures within that junction. Typically, we tend to see antibodies against nicotinic acetylcholine receptors, but in some cases, we can develop antibodies to MuSK and LPR4 as well. These are all sort of proteins involved in the transmission of that electrical signal into a chemical signal for muscle activation. It presents with weakness, which is progressive. So it tends to be, for example, at the end of the day, the patients become more aware of their symptoms, or during a clinical exam, there is what we call fatigability. So in repeated movements, we tend to then see that weakness appear. It typically affects the eyes around sort of the muscles and bulbar muscles, so the muscles of the face that allows to speak, swallow. So the typical symptoms will be ptosis, so drooping of the eyelids, diplopia, dysarthria, dysphagia, but we can also get some limb weakness as well, predominantly of the upper limb, and some dyspnea in the cases especially of a myasthenic crisis, which is most commonly seen during a period of illness. So, for example, respiratory infections can be a very big trigger for myasthenic crisis, and that can present with troubles breathing. Because of the nature of the condition, we don't see muscle wasting. There's obviously, we said it's the neuromuscular junction that's affected, so we don't expect sensory deficits, and reflexes will be normal. How do we treat it? We use acetylcholinesterase inhibitors. Commonly, the most common one is pyridostigmine. We can also use neostigmine. Pyridostigmine is preferred because its effects last longer. We can use immunosuppressants. They're not super commonly used, but if we were to use them, then glucocorticoids and azathioprine are also used. And then in the cases of a myasthenic crisis, we would use IVIGs and plasma exchange as well in this case. So I thought I would include this. It might be maybe less common than the other ones, I would say, especially in exam questions. But I thought it would be a good one to touch on, especially to compare with some other syndromes or conditions that can present in a similar way. So Horner syndrome is caused by a sympathetic damage. And this can be secondary to a number of things, including tumors or strokes of the brainstem, syrinx of the spinal cord, apical lung tumors that will impinge on the T1 nerve root, as well as migraines because of the changes that we get in the blood vessels during a migraine that will increase, that essentially will make the artery press on the sympathetic plexus. And typically will present with ptosis, so again, drooping of the eyelid, miosis, and anhidrosis. Now, it's important to be able to, what I like to do when I think about neurological condition is try and think which ones may perhaps present similarly and understand the physiology underneath that. So something that may present what looks or could be like Horner syndrome is a third nerve palsy. But the difference here will be in, for example, the eye. You'll see a clear deviation in the eye that's affected, on the side that's affected, and that is because of the effect of the oculomotor nerve on the extraocular muscles. But that could also present with ptosis. And then another one that you might see some symptom overlap with it is Bell's palsy, and that can also cause drooping of the eyelid, but it will also present with some sort of facial nerve defects that wouldn't present in the other one. So we'll get the ipsilateral drooping maybe of the mouth and the non-sparing of the forehead, which wouldn't be present in the other syndromes. But it's important to sort of to be aware of these conditions and see which things they have in common and which ones they don't, to be able to properly characterize the picture that you have in front of you. So this is an example question. So we have a 35-year-old male which presents with unilateral right-sided loss of dorsiflexion. He has no significant past medical history. He's otherwise fit and healthy. He's a frequent gym goer. His mother suffers from rheumatoid arthritis. On examination, you notice diminished ankle inversion and hip abduction. There's no pain on there is pain on ipsilateral straight leg raise test and loss of sensation over the right plantar surface and lateral calf. Knee jerk reflex is preserved. What structure is most likely to be affected? Peroneal nerve, femoral nerve, sciatic nerve, L5 nerve root, or L3 nerve root? And maybe I'll just give a few minutes. I don't expect answers to come through. I just try and work it out based on the history and the signs that we've given you. So okay. So sometimes the age and the person that's presented to you might be relevant as a clue as to what might be going on, sometimes not. We have a 35-year-old male, so we're also told that he's otherwise fit and healthy, but that will give you, the age might give you an indication of what pathologies we might be expecting in this individual. That presents with a unilateral right-sided loss of dorsiflexion, which is in other words foot drop. Foot drop can be caused by damage to a nerve root from L4 to S2. So we can maybe start to rule out a few things from our options. He has no significant past medical history, but he's a frequent gym goer. This could be an insight into the mechanism of injury. We don't know. His mother suffers from rheumatoid arthritis. This is something that's there simply to distract you, really. It might be relevant, but it's unlikely at this stage in this case. In terms of the exam, you notice diminished ankle inversion and hip abduction. There is pain on straight leg raise. So that is typical, that is the sciatic sort of type of pain, and the nerve root are typically L4 to S1. Again, it might start to rule out a few things such as femoral nerve that shouldn't cause this type of pain, or it wouldn't present in such a way. Then it tells you it's got loss of sensation of the right plantar surface and lateral calf. So already, if you try and picture the dermatomes, we're looking at dermatomes that are further down the line. So typically, already in my head, I'm thinking around L5, perhaps some S1 as well, but I'm not thinking higher than that really, because that should be somewhere around your thighs. And then it tells you finally the knee jerk is preserved. So L3 or 4, kick the floor. This is very much embedded, I feel, in most medical students. So already we can rule out then that the L3 nerve root, and therefore by that way of thinking, we can assume that it's probably the L5 nerve root that's affected. And In fact, this could have been caused by a sudden movement at the gym, maybe lifting a very heavy weight that could have caused a disc to perhaps herniate and press on the root and cause these symptoms. And it would be quite common given the age and the onset of the symptoms, the fact that it's unilateral. So yeah, this is one way to work out through this question. Question number 2. It's a 45-year-old male presenting with unilateral left-sided wrist drop and dorsal numbness over the left hand. His past medical history is significant for hypertension and hypercholesterolemia managed with statins and ramipril. There's no relevant family history. He first noticed his symptoms this morning after a night out with his friends on a bachelor party. What structure is most likely affected? Radial nerve, ulnar nerve, C7, nerve root, L5 nerve root, or L3 nerve root. Again, I'm just going to give you a few seconds. For those of you that will be following this on YouTube, you can probably pause, have a think. I don't want to take too much time. Okay. So again, may be relevant, may not be relevant to the person that's presented is. This is a 45-year-old male with a unilateral, so once again, unilateral left-sided wrist drop and dorsal numbness. Already, this should be ringing some bells. The fact that he's got hypertension, hypercholesterolemia, and the medications that he's on, I think, again, it's a bit of a distraction here. It might be maybe trying to represent a metabolic derangement and therefore make you think a neuropathy, but actually the question is not asking you about the pathophysiology, it's asking you about the structure that's most likely affected. And then it tells you that these symptoms have occurred this morning after a night out. So the rest, actually, I think most of the information for this question is in the top paragraph, which tells you the motor and the sensory defect. And in this case is wrist drop and dorsal numbness only on the left side. So in this case, we know that this is the radial nerve, which controls finger extension, wrist extension, and thumb extension, as well as thumb abduction, and supplies the sensory fibers to mainly the back of the hand, whereas the palmar surface, it's mainly the median and ulnar nerve. So automatically, we can exclude, we can assume it's the radial nerve based on those, if you know, that's the presentation of a radial nerve palsy. And one of the common signs or causes of radial nerve palsy, of acute or sudden radial nerve palsy, is when we compression of the radial nerve. And one of the conditions is called Saturday night palsy, and that is because of falling asleep, for example, over a chair with your arm pressing on the nerve. And that typically tends to resolve anyway quite quickly. So it's only a temporary presentation. Okay. So again, relatively, I think, straightforward question. You just need to remember essentially which muscle group your nerve will supply and what their sensory distribution is. Moving on to central nervous system lesions, perhaps a bit more exciting. A very common one that you see often is MS, multiple sclerosis. Now, just like Guillain-Barré, this is also demyelinating disorder, but it actually affects the myelin of the central nervous system. There isn't an obvious genetic, an obvious underlying genetic cause, but there is a susceptibility associated with certain HLA haplotypes, such as DR15 and DQ6. And there's also a link with some environmental factors, such as an infection by EBV or HHV6. How does it present? The presentation varies, essentially. There will be your textbook presentation, but then obviously the presentation will vary depending on where the lesion is located. So one of the most typical ones you read on a textbook is optic neuritis, which is painful eye movements, visual loss, and relative afferent pupillary defects. We can also have, however, limb weakness or paresthesias, dysarthria, ataxia. All of this, like I said, will depend on where the lesion is. Three sort of relatively interesting or presentations of MS to keep in mind are Uthoff's phenomenon, which is when the symptoms become worse when the body temperature is raised, for example, after a hot shower. Lhermitte's phenomenon, which is when neck flexion can cause paresthesia, so this abnormal sensation, and internuclear ophthalmoplegia. So these are the main ones you'll hear of if you sit in clinic or reading books and case presentations. The disease can present in different ways in terms of symptoms, but also in terms of progression. So the most common type of MS is relapsing remitting. So we get this acute onset of symptoms that resolve, and then there's a relatively stable period, and then there's a new symptom perhaps, which again presents acutely and then resolves, and so on. A percentage of these cases, so almost 50% of these cases will develop what we call secondary progressive MS, which is essentially when the disease, instead of relapsing and remitting, going back to baseline, the baseline sort of over time worsens. And the symptoms don't necessarily always improve completely. They might improve slightly, but not go back to the initial baseline. And primary progressive MS is the least common of all the presentations of MS, and this is when essentially the disease, we don't get this acute onset and resolution that we see in the other ones, but rather we see a steady progression of the condition. And so you can imagine the burden on patients of this type of MS is much bigger compared to, for example, the relapsing remitting form. How do we diagnose this? CSF analysis again, we look at oligoclonal bands. It's important to know that these will present in multiple other sort of inflammatory states. So it's not just specific to MS, but it is a good clue when we're trying to diagnose it. So when it comes to actually the diagnosis of MS, we're looking more of a picture. So we're looking at the symptoms, we're looking at the imaging. So we need to have evidence of lesions. And we tend to see this on a T2 weighted MRI scan of the brain and spinal cord. And again, the CSF analysis will back this up. And there's different criteria that we use. One of them is the McDonald criteria to make an official diagnosis of MS. So it's not just a clinical presentation. It can't be just the evidence from imaging. It needs to be a combination of things. Did I go? Yeah. Okay. Another question. This is a 32-year-old female presenting with double vision and droopy eyes, usually presenting in the evening. Lately, she has been feeling more fatigued than usual, running out of breath when attempting the stairs to the 3rd floor. On exam, there is fatigability, reflexes, and sensation are intact. She has no significant past medical history. Her mother, who's 65, has recently been diagnosed with polymyalgia rheumatica, and she thinks this may be related. A recent chest X-ray shed upon her GP's request for the shortness of breath showed a central mass just superior to the cardiac shadow. What is the most likely diagnosis? Fibromyalgia, MS, myasthenia, Lambert-Eaton, or migraine? And again, just a few seconds. Those of you following from YouTube can pause, have a bit of a think. And the answer is myasthenia gravis. I apologize, I feel like I threw this in a bit later whilst we're talking about central nervous system lesions. But I wanted to show you how similar in a way all these conditions can be. And we need to play a bit of a detective role when interpreting our symptoms. And that's really the key in neurology, is putting together all the signs and symptoms and trying to trace back what the initial cause could be. So in this case, I think that the fact that she's a 32-year-old female is already sort of hinting at some of these conditions. Why? Because we know that things like MS or myasthenia can present at a specific, can affect certain populations more than others, so females, and especially females in this age bracket. So it is a high risk age group, but obviously we can't make any assumptions just based on that. Presenting with double vision and droopy eyes. So again, like I mentioned earlier, myasthenia gravis tend to affect the muscles of the face more than the limbs, and this progressive feature that it occurs over the day. So by the end of the day, so it gets worse in the evening. It then says that she's been feeling more fatigued, which again is in keeping with all of that, and out of breath when attempting the stairs. And so we're getting some of that dyspnea that we're talking about. On exam, there is fatigability, so that proves what we said initially. Reflexes and sensation are intact. So that is a key distinguishing feature between, for example, MS and MG. So in myasthenia gravis, like we mentioned earlier, we're not expecting any sensory deficits. We're not expecting any reflex abnormalities because of the nature of the disease. I guess one could argue that in MS, the symptom presentation might vary depending on where the lesion is. But I think, again, this is giving us a clue as to what the condition could be. She has no significant past medical history. Her mother has PMR. Now, this is 100% there just to distract you. There's no clear genetic link, and PMR tends to affect the older age group, and there's not a connection necessarily with PMR and, for example, fibromyalgia. A recent chest x-ray, the other thing I was going to say is that fibromyalgia, if you were thinking, oh, why is this, for example, not fibromyalgia? I think the fact that the symptoms present towards the end of the day, and there is clear fatigability during a neurological exam, that shouldn't be the case with fibromyalgia. So this is an extra clue in case you're still unsure about what the cause might be, or perhaps it might have acted as a distractor for some people, is the fact that there's a central mass superior to the cardiac shadow, and this is suggestive of a thymoma. So generally, all patients that are being investigated for myasthenia gravis should also have a chest x-ray to rule out a thymoma. They're commonly seen. This is together, it's due to the immune system being overactive. And perhaps it might have been a bit distracting to some people, especially those that knew very well about Lambert-Eaton, might have thought maybe this could have been lung cancer, because actually a very good differential diagnosis to think of when we think of myasthenia gravis is Lambert-Eaton syndrome, but the mechanism is very different. So first of all, this is immune, but it's paraneoplastic, so it's seen in association with cancers, typically lung cancers, and specifically small cell lung cancer. It targets voltage-gated calcium channels, not nicotinic acetylcholine receptors. And instead of having this fatigability feature, it's quite the opposite, actually. The symptoms in Lambert-Eaton improve with use. And they can cause reflex changes because of the pathology, so the etiology of the disease, and it can cause autonomic dysfunction. And the reason why we don't see autonomic dysfunction in myasthenia gravis is because we do not have nicotinic acetylcholine receptors as part of the autonomic nervous system, whereas we can have them. We can have voltage-gated calcium channels. So a few things to keep in mind, but I think this was an easy one to fall, sort of, especially given the last bit of the text. Okay. So next, and I believe last, is motor neuron disease, MND. So very terrible neurological condition. This is a progressive degeneration of the motor neuron specifically, including the upper and the lower motor neurons. It can be sporadic, and it's also been found to have some genetic risk factors. One of the most common genes involved in MND is superoxide dismutase 1. There is also a correlation with some forms of frontotemporal dementia. So there is some genetics involved, but the disease can also be sporadic. the presentation will vary as well. So we can get, I put them in order of severity. You're not expected to know all the different types, especially for your exams. You're just expected to be able to pick up the features of motor neuron disease. So everyone, so primary lateral sclerosis is involves upper motor neurons mainly and is symmetrical. Progressive muscular atrophy is a small amount of cases, but it presents with lower motor neuron size mainly. ALS is the most common one that you might have heard of, and it presents with the typical mixed picture of upper motor neuron, lower motor neuron, with and it can be asymmetrical. And then we get progressive bulbar palsy with dysarthria and dysphagia. So generally speaking, the life expectancy will reduce as we go further down this list. So progressive bulbar palsy is the one with the shortest lifespan or prognosis after diagnosis, and primary lateral sclerosis is the one with the better prognosis upon diagnosis. So with progressive bulbar palsy, I believe we're looking at about 5 years or less. With primary lateral sclerosis, it can be much longer, so 15, I believe, and above. The clinical presentation, so I already mentioned affects the motor neurons, the upper and the lower, so we can get muscle wasting, we can get fasciculations, we can get dysarthria, dysphagia, so the bulbar muscles involvement, weakness, obviously. But it can also cause cognitive and behavioral changes, and that is part of that association with FTD that I was talking about. Now, a good way, I think, to go through this is by having a clear idea of what a upper and lower motor neuron lesion looks like or would present like. So I put in a table, and the way I like to think in neurology, because there's so many things that could be going on and sometimes it's a bit hard to put things together, is using a structure. So I try to follow the same structure as we follow during exams with look, feel, move. So in between, so upper and lower motor neuron lesions, just by looking at patients, we can get atrophy or wasting of the muscles, predominantly in the case of lower motor neuron lesions. But we can also get it in upper motor neuron lesions over time if there's a prolonged lack of use of the limb, for example. Fasciculations are a feature of lower motor neuron lesions only. We're not expecting them in upper motor neuron lesions. Tone will be significantly different, and this is to do with all the reflex pathways. So in upper motor neuron lesions, we tend to see increased tone, and particularly we tend to see spasticity. So that is knife clasp increase in tone that we see in some, I don't know, you might have come across it, you might have heard of it. Whereas in lower motor neuron lesions, we get flaccidity, we get reduced tone, and that is why, going back to Guillain-Barré, we were talking about that flaccid paralysis, because it's a peripheral, so a lower motor neuron, lower motor neurons will be affected. Weakness will be obviously present in both, because the motor neurons are affected. Reflexes, for the same reason our tone is increased in upper motor neurons, will be increased in and will be decreased in lower motor neuron lesions for the same reason the tone is reduced and we get flaccidity. Similar to reflexes is clonus. You might want to, it's a bit difficult to explain. I would say the best thing to do is probably Google a few of these on YouTube. There's plenty of them just to have as a reference in your mind of what you're looking for when you're examining a patient. But again, just like reflexes and tone will be increased, we'll expect clonus to be present in an upper motor neuron lesion, and we wouldn't expect to see it in a lower motor neuron lesion. And finally, there's a few tests that we can do to see if you probably come across these before, to see if the lesion is central peripheral. One of these is the Babinski or plantar reflex. So that is when we stroke the plantar surface of the foot with a sharp object and we expect the toes to either curl up or inwards. So normally you'd expect them to go inwards, but if they go up, that is an abnormal response. That is a positive Babinski, and that is suggestive of an upper motor neuron lesion. That would be negative, so the toes will curl normally in a lower motor neuron lesion. Now, this is sometimes a bit hit or miss. The results of this test can sometimes be equivocal, so it's important that we rely on multiple things during our exam to be more accurate with our diagnosis. So having those in mind now, last question. A 42-year-old man is referred to the neurology clinic with an 11-month history of progressive weakness. It began in his right hand, where he noticed difficulty turning keys and opening jars, but now it has started to involve his legs, tripping whilst walking. In an eye, sensory symptoms are visual disturbances. On examination, there is right-sided weakness of finger abduction with mild wasting of the first dorsal interossi, bilateral Hoffman signs present. Lower limb deep tendon reflexes are brisk. Sensor examination is normal. Nerve conduction studies show reduced compound muscle action potentials. What is the most likely diagnosis? So we've got cervical myelopathy, multifocal motor neuropathy, ALS, Guillain-Barré, and myositis. So again, a few seconds for everyone to have a think and potentially pause. And I'm going to move on. So the answer is ALS. Why is it ALS? So 42-year-old man, this is a high-risk group, 11th-month history, so this is not something acute. So you wouldn't necessarily expect this history from something like Guillain-Barré. You could expect it for something like cervical myelopathy that is progressive. So again, could be in keeping with some degenerative spinal changes. So difficult to make to assume anything just from these few lines. It began in his right hand, but is now starting to involve the legs. So this is important because we're now seeing changes on multiple root levels, suggesting that perhaps it's not like something like a cervical myelopathy, for example. And equally, this jump is not typical of Guillain-Barré syndrome, although we did discuss there are different types of Guillain-Barré. We wouldn't expect this type of disease presentation, especially in the absence of any triggers that could have caused this. And this is not the picture that you would expect in myositis either. The fact that it's a difficulty turning keys and opening jars, I think is trying to make you think along the lines more of cervical myelopathy because of the loss of fine movements. But here it's, I wouldn't say a distractor because it's still giving you an idea of the presentation of the symptoms. But I wouldn't base much of my judgment about how to answer this question based on that detail. We have weakness of several muscle groups, but no sensory deficit. So again, this is telling me it's a motor involvement rather than something that can affect the sensory nervous system as well, or the autonomic nervous system as well. Then we get the distinguish between, or rather, we get both lower motor neuron, upper motor neuron signs, which we also said is quite typical of ALS, this asymmetrical presentation of upper and lower lesions. And the lower motor neuron lesion sign is the weakness and the muscle wasting, as we discussed. If it said fasciculation, that would have been another one. And the upper motor neuron lesion, its sign is Hoffman sign, a positive Hoffman's. This is similar to a Babinski test, but instead of doing so we do this one on our hand, and it's an involuntary movement of your fingers when stroking or flicking the thumb. Again, I think it would be easier if you saw it online. It will give you a better idea of what you'd be expecting. But yeah, so that is a sign of an upper motor neuron lesion. So the presence of both at this point is quite, it confirms that the most likely diagnosis is ALS. And then obviously we get the nerve conduction studies, which show reduced compound muscle action potential, and that is, I think it's even a bit too obvious at that point. But yeah, hopefully this was a relatively straightforward one. I would say my top tip answering exam questions, at least what works for me, is before I even read the stem, I read the question. Because otherwise, when you read the stem, you're being overwhelmed with information. Some stems can be very long. So you just need to know what information you're looking for. So then when you're reading your stem, you know what to filter and what to focus on. So because the question could have been, what is the most likely mechanism of injury or the most likely underlying pathology? It could have asked something different. So you need to be able to pick out the right information, and you need to answer that question. And these are just some resources that I used. This is a few books that some for leisure perhaps, and some more to get a better understanding of certain presentations. So especially the clinical neuroanatomy, I think it's it's quite old, I believe now. But it is truly made ridiculously simple. It breaks down things in a way that are very easy to understand, especially if you're struggling a bit sometimes to understand the different pathways. This is a good one to go back to. Neuroanatomy books are always helpful, especially if you're more of a visual learner. I find those can be, because they often associate the anatomy with this one in particular will explain the anatomy, will break it down into systems, and then present some common presentations that come with certain with some anatomical defects. So I think it's quite useful to have them side by side. And the Oxford Handbook is always a good summary of management presentations, etc. And the latter, I feel like, are more for you to enjoy in your free time if you like neurology and you want to have a nice read outside of the textbook. And yeah, I don't have a chat function, so unfortunately maybe I won't be able to pick up any questions, but I hope this was useful. It is a feedback QR code. And yeah, stay tuned for more sessions. We definitely have a few more coming up. I know a few of you have already sat their exams, their final year exams, but this is all, I feel like, also helpful for OSCEs. So come for the remaining sessions and good luck.